We're here at Euromigos meeting 2025. We're wrapping this up. This is the last of the podcast, actually. I'm keen for it to remain well-mannered, possibly.
Yes.
Okay, so that's important. That's important. Okay. I'm Tom Poles. Hans, Monty Powell, we're good to go. Listen, before ESMO, we were in Rampart came out there. We'll talk about that specifically. But let's just summarize fairly quickly where we got to. What we had was a positive trial with adjuvant pembrolizumab in a big randomized study across broad subgroups of patients. We're not going to go into too much detail about the subgroups. Actually, I don't think there's much to say about the subgroups. It's a positive trial. It hit disease-free survival. It had significant overall survival, about a 5% delta in OS. It's associated with life-changing toxicity. I tell my patients about a 10% chance. Other people might come up with other figures. There is a series of other trials that were not positive. Atezolizumab, some people say it was because of PD-L1. Ipi-Nivo, some people say toxicity, other people say shorter periods of therapy, other people say just don't know, sometimes there's noise. There was a neoadjuvant study with nivolumab called PROSPER. This is a drug I'm offering to my patients. Not all of them are taking it. There's a risk-benefit ratio. Lots of factors go into that, but I think it's the right thing to do to offer it to our patients. Where do you stand with this?
Agree.
Hans, your position on this, on the trial, there are components of the trial that made you a little bit uncomfortable. And I'm keen that, we just go through some of those.
No, it's really just more about what do I tell my patients?
Yes.
How do I position it?
Right.
And, the truth is, the lower the risk, the more guilty I feel if something life-altering happens, right? If they get the type 1 diabetes, adrenal insufficiency, other toxicities, etc. So for me, it's more like, let me position this in a way that you actually have a choice, which is immunotherapy now or later. Yeah. And I feel comfortable with that because in my practice, virtually every patient will get immunotherapy at some point in the treatment course. And I just don't use the OS data as the persuasive one to say, you're going to live longer in my practice if I'm going to give you immunotherapy super early versus if I give it to you later when I see the disease coming back. When I use actually 2 immunotherapy drugs, which adds to the complexity in the discussion. Yeah. Because for some patients, I may even feel that they're undertreated with just 1 drug.
Early immune therapy may be more effective than later immune therapy. It probably is. Do you agree with that statement?
I do not agree that early immunotherapy in the micrometastatic disease space is necessarily more effective than later. I do not believe that. And I have not seen data to that end.
And achieving overall survival in adjuvant studies is extremely challenging. We never achieved that with nivolumab in bladder cancer, and yet we still, we had to close trials because we felt it was unethical to keep enrolling those patients.
I understand,
and
but
so,
the
then
trial
the same
did
time,
not answer the question conclusively. If super early versus delayed would actually have that, because for that you would have to have every patient on the placebo arm also.
Oh, that's not possible.
I know. And that's what I'm saying. Is that's why the trial didn't answer. It's really more a trial that supports that immunotherapy is important for outcome in patients.
But you don't. One of the challenges is not everyone gets subsequent immune therapy. We know that unfortunately we can't follow patients around and give them all immune therapy. And we know, for example, in the UK series where immune therapy is widely available, only 60% of those patients get immune therapy. Yeah. And in the trial, about a similar proportion of those patients did get immune therapy. So you could say that actually in this trial, this is a pretty pragmatic study. This is what happens, and you get significant survival.
All I'm saying is that's how I talk to my patients, because all of my patients will get access to immunotherapy. I still feel strongly that they have a choice of doing it now versus later.
But later could be worse.
I don't believe that, because I cure patients at any time in the treatment cycle with dual immune checkpoints. And so I do believe immunotherapy can work really well in grossly metastatic disease, in micrometastatic disease. Well, that's all I'm trying to say.
Yeah, no, I understand that.
But I don't use it as an argument to say, if you don't do it now, you're foregoing something. You will not have a survival benefit if you don't do it right now.
I like that. The adjuvant immune checkpoint combination, Ipi-Nivo, was not positive. Does that put any weakness in the dual therapy argument?
No, it does not.
It does put some weakness. So some 1% weakness, 2% weekness. It must put some weakness. In your mind, there must be some weakness. It's a negative trial. You can't say, okay, look, we need to move on. Hans, should we move on?
Yes. Okay, very good.
Okay, the good news is There was a positive trial with CTA4-PD1 called Rampart.
Yeah.
That strengthens the argument a little bit.
Yeah,
around the
so now
combination.
you're a believer in dual immune
No,
checkpoints. I knew it.
I'm not. No, I'm not. Because we didn't see the single agent durvalumab arm. And it's possible that durvalumab arm is driving all of the benefits.
All of it.
It's possible.
All
Well,
of it.
hold on a second. The adjuvant ipi-nivo trial was negative, and the positive pembro trial was positive. The single agent pembro trial was positive. So it's possible the single agent durvalumab, we don't know that, not true yet.
Yeah.
Monty, perhaps you might like to say something.
Not really. No.
I'm going to keep going. Go ahead. So I'm going to give a summary of the Rampart trial, if I may, because I'm in all seriousness.
Yeah, it would be great.
In all seriousness. So it's a randomized phase 3 study. It's an investigator-initiated study out of the UK, France, and Spain. Patients were recruited to receive durvalumab or best supported care in the adjuvant setting in a high-risk group. This trial stopped early because adjuvant pembro became available. It felt unable to continue. It was somewhat underpowered, therefore it also included papillary cancer patients. So it's a bit of noise there. Also, it's an open-label study, and investigator-assessed endpoints, and so we need to be just a little bit cautious. But the study is positive. It's got a good hazard ratio in the 0.6s DFS. We've not seen overall survival yet, and as I said, we've not seen that monotherapy arm yet. And so there's a lot of uncertainty, but it does strengthen the argument that certainly it strengthens the argument that immune therapies are active, but it doesn't really resolve the issue about how much CTA4 is adding yet until we see that durvalumab arm. Now we will see that. It wasn't included this time, not because we've seen it and didn't want to present it, but because the statistical analysis plan wanted to go for the dual arm first and then come down to the monotherapy arm afterwards. So that's fair enough. How does it change your mind, Monty, about how we look at this disease?
It doesn't. I think 564 set the bar kind of high for me, right? So, until I see that there's any sort of survival signal from this, I'd probably just stick with adjuvant pembro.
Yeah. I would say, what I like about Rampart is that there might be a patient population where I would use Rampart, especially in the very higher risk patients where I feel that the CTLA4 component might be important. Sarcomatoid renal cell carcinoma, right? There was no real enrichment on Keynote 564 for sarcomatoid.
There was some enrichment in 214 actually in sarcomatoid, wasn't there?
In 214 for sure, response rate for but not with Keynote 564, right?
Yeah, so there was
so in those patients, I'm actually feeling maybe under treating, right? Yeah. And so in those patients, right, the dual immune checkpoint might be actually quite interesting.
You're definitely into the dual thing. I can see that. Now we're going to keep talking about duals because we're going to talk about a press release that came out just a few minutes ago. That was a few minutes ago, a couple of weeks ago. Belzutifan,
yes,
LightSpark 22, in the Belzutifan plus Pembro versus Pembro trial. Belzutifan HIF2 alpha inhibitor, novel mechanism of action, direct tumor target, although it does probably go down the angiogenic axis, but it is working in a slightly different way. Monty, when you saw that press release, were you surprised? It's 1,800 patient adjuvant trial, because you could look at it different ways.
Indeed, but I have to say, participating in the study, I will say it was easier for me to get my patients through what I assumed to be sort of the experimental therapy arm over the course of a year. Participating in the adjuvant TKI studies, I could never get a patient through a full year of adjuvant sunitinib or sorafenib. That was very challenging.
Hans, in our session a few minutes ago, you talked quite eloquently about the mechanism of action and how you felt this may be, you weren't sure if it was going to help or be a hindrance, and you were pleasantly surprised.
Yeah, so I'm obviously open-minded about the data set, but I need to see the details, obviously. I know. But I would say the unique aspect of the HIF2 inhibitor is that it's different than a VEGF TKI. It can have direct anti-cancer activity. So this is a space where, similar to chemotherapy in breast cancer, right? It may not necessarily be curative, if you will, or have significant OS signal in the macroscopic disease space, but in the microscopic one, maybe you're going to even cure some patients. Who knows? The drawback or disadvantage of a HIF2 inhibitor with immunotherapy is also something that is coming under debate, and that is that it might actually decrease the immunogenicity of the cancer, right? So there are actually data from patients from bone marrow transplant trials that some of these patients were cured by clones that targeted human endogenous retroviruses, which are driven by HIF2. They're dependent on it. There was a very, very, very well published paper by Bill Kalin in Cell showing that HIF2 drives tumor antigenicity in clear cell renal cell carcinoma, which, by the way, may explain why it's so much more immunotherapy sensitive than the tumor mutational burden would suggest. So I think there are some concerns some potential advantages, and we will have to see what the data set is going to look like. What I don't want to compromise is the long-term outcome. So I will always look very carefully at potential long-term outcome, trends in overall survival, things of that nature.
So we're going to look at the data set there. It's an exciting study in an area that we thought was going to be difficult. Deep down, my feeling on this, for what it's worth, is I was encouraged with single agent belzutifan activity. I would have liked to see, we all would like to see significant survival versus everolimus. We didn't, but it did show activity. And I felt coming earlier in the disease, particularly in those VHL patients and more angiogenic tumours earlier, I did feel it was going to work a little bit better. So I wasn't surprised it was positive in that adjuvant setting for DFS, and I'm really encouraged by that. I also would like to see, obviously if the hazard ratio for OS comes in at 1.1, then we're going to have to think again, it's immature, but it would be nice to see that OS trend. As a European, we love OS in these trials.
Sure.
It's probably still a little bit early for significant OS. So we're really looking forward to that study. Is that right?
Yep.
Indeed.
I've enjoyed this, Hans, and we managed to get through it.
Very good.
Congratulations.
Yep.